Good afternoon, everybody. Welcome to CIT Echo. We'll let Dr. Rosamond figure his phone out. It's good to see you guys. As always, we'll get started with introductions. And I think today we'll start with the folks in the room, starting with you, Cody.
I'm Cody Maxwell, I'm a detective with the Crisis Intervention Unit.
Sergeant Charles Crook with Albuquerque Police Crisis Intervention.
Detective Shannon Mieta with APD CIU.
Detective Ben Melendres with APD CIU.
I'm Elizabeth Ferre. I'm a psychiatry resident with UNM.
I'm Kim McManus. I'm the CIT Echo Project Coordinator.
Niels Rosenbaum, a psychiatrist with the Albuquerque Police Department.
And then we'll get introductions to those connected online. I see Peter Modis. Not sure if you have a mic, sir. Perhaps not. I see Michael Estrada.
Michael Estrada, probation parole officer in New Mexico Corrections Department.
Welcome. I see Deputy Mackey.
Hello.
How are you?
Having some issues with technology at the moment.
No problem. I see Lieutenant Brian Price from APD. Not sure if you have a mic.
Good morning. I do. I just couldn't get it off.
Welcome, LT. So we'll begin today's session with our case. Detective Shannon Mieta is going to present that. So whenever you're ready.
Hello, good afternoon, y'all. I have a case today for you guys. This is a recent CIU referral that our unit has received. We received this referral now in, I believe, July. This individual is 40 years old, or he's just about to be 40 years old. He is a Hispanic male. How he came to our unit is there was a call for service involving him, and he jumped out of a second-story window in order to commit suicide. The attempt failed, and he armed himself with glass, at which point he was self-harming when officers arrived on scene, and was threatening to commit suicide, and also threatened to commit suicide by cop. He was challenged by police officers, and force was used into taking him into custody. He currently has pending charges for that crime. He is currently in the hospital. He has aggravated assault against a PO for that. Looking into his history, starting around the year 2000, he had an indictment for murder, in which case he pled to manslaughter and did about 2 years of incarceration, 2 to 4 years of incarceration. From that, he had a couple of DWIs and a battery in the subsequent years. However, there hadn't been many reports from 2011 until this year. We seem to find that starting in May of this year, he started having a bunch of calls for service. One was where he was hallucinating and believing people were following him with weapons. He was transported to the hospital for that. Another call in June seems to show that AFD was called to the scene because he had blood all over himself and he had self-harmed, and that he was hearing voices. He again was transported to the hospital. And then came the case of where he was referred to our unit. Right now, again, like I said, he is currently in the hospital, awaiting to be incarcerated or sent to jail for his pending charges. I guess the question for the network is, what resources maybe can we recommend to the DA's office or to the correctional systems for him, because as we know, he probably will be out sooner than later. And if you all think a dangerousness hearing would also be a good idea in this case.
This is Mike from probation parole. I think I would recommend to the DA's office that he be placed on what we call community corrections, which is our mental health unit in the probation parole division. And Detective, did you mention a competency hearing?
We have not mentioned a competency hearing, but if you guys think that that would be a good recommendation, I would like to hear your thoughts about that.
I would defer to Dr. Rosenbaum for that.
Sure.
Mike, oh, shoot.
My guess is a competency hearing is probably going to happen. I mean, because anybody, as you know, anybody can bring it up. So the defense can, the prosecution can, or the judge. So of those three, someone's going to bring it up. And I don't, what is the current charge?
Right now it's aggravated assault against the police officer.
Oh, okay.
Enforcement. Sorry, I did want to go back. So far, the only thing we have heard of his diagnosis is unspecified delusional disorder.
Okay.
And he does have history of alcohol, heroin, and meth use in the past.
Yeah, I mean, my guess is someone will bring it up unless it's a very clear cut of like using meth and becoming psychotic, and now he's perfectly fine. But if he has any residual symptoms, someone will bring up a competency. I would be very surprised if no one does. And he didn't commit a crime that would, like if you commit rape or murder, or rape of a child, I forget, arson is the other one. And someone brings up competency, you have to be treated to competency. So that what they do is they send you to, this is what happened to John Hyde, they send you to the BHI, the state mental health prison, essentially, and they keep you there indefinitely until you're treated to competency, but he's never been treated to competency. And so some people, they just eventually just let go. Like he's not, we can't treat them to competency, but we can't keep them here. So there are people with traumatic brain injuries have like murdered people or committed arson that eventually they're just like, yeah, we can't keep them, and they have to let them go. So fortunately, this guy doesn't fit into that category. But if you ever want to burn down a house or something, have a brain injury beforehand, and then you can get out.
Great advice from Dr. Rosenbaum.
That's solid advice.
I think there was some stuff I missed. Dr. Frey, would you mind doing just a quick recap?
Sure. So this is a 40-year-old male with a known history of unspecified delusional disorder, alcohol, heroin, and meth use. A recent CIU referral in July. Sounds like he's currently in the hospital awaiting incarceration on a charge of aggravated battery against a police officer. And some additional history, he jumped out of a second-story window and then in a suicide attempt, and then consequently self-harmed with glass and was threatening suicide by cop. That sounds like his most recent interaction with law enforcement. And the question is, what resources can we recommend to the DA's office?
Yes, thank you.
Yeah,
Thank you. We've already had a few recommendations. Does anybody have any other recommendations or clarifying questions about this case?
This is Mike again from State Probation Parole. If you guys think he could be stabilized at MDC, I might recommend a year at MDC for stabilization, followed by supervised probation. So it would be a partially suspended sentence with jail time. I'm not sure that the prisons would do a great job of stabilizing him. I'm thinking he would get better service in MDC. So that would be a suggestion.
Thank you. That's a good.
Those are both great suggestions.
Yes, great. Thank you, Michael. And I know that he has had his original manslaughter or downgraded manslaughter. He did have a lot of in-house probation and probation status with that. So.
Any other follow-up questions or recommendations from the network?
Should we just talk about delusional disorders?
Yeah.
Yeah, if you can, Dr. Rosenbaum, I wasn't quite sure what unspecified delusional disorder.
So that's a great question, and I can chat about that for a little while. And if anybody has questions, please jump in. So delusions, just to refresh everybody's memory, means it's a belief that's not true. So if I believe that I'm the son of the president, you guys would probably think that's untrue. But if it turned out that Biden had adopted me at some point, that's not actually a delusion. That's just you guys not knowing the whole truth. And so a delusional, someone can't really be labeled as having a delusion until you what's called reality test. So reality testing means, well, here's reality. I'm going to test it against your beliefs. So you say you're president's son, prove it to me. And so let's say I show you a birth certificate, or I show you that I was adopted as an adult by Biden. Then I passed that reality test. Most people fail them. Some delusions can be so outlandish that they no longer fit in delusional disorder because this is how it used to be. You'd be schizophrenic if you had bizarre delusions. They've taken that out now. So if I believe that if I have a delusion that's possible, like I believe that I just inherited $15 million, that's possible. And then you reality test me and I can't produce any documents, or I show you a bunch of random papers and they don't make any sense, then you know I'm delusional. But if I have a delusion that the aliens have taken out all my organs and replaced them with diamonds, and my brain is a big lump of, I don't know, water, you don't have to reality test that because that's a bizarre delusion. And so in the past, that used to be just that one symptom was enough to be considered schizophrenic. That has since changed. But most people with bizarre delusions generally have other symptoms going on. So that could be anything from substance use disorder. So they'll have signs and symptoms of using substances, or they'll be disorganized, because most people with schizophrenia are disorganized in some way. And delusional disorder is interesting because it's usually very prescribed. It's usually very narrow. So people with delusional disorder, it's usually like erotic, like this person's in love with me, or you're having an affair and I know it. I know you're having an affair. No matter how much the spouse says, no, I'm not, you can follow me, you can read every email I've ever written, they won't believe it. So it's very circumscribed. So they might have an otherwise functioning life, but a delusional disorder is usually one specific delusion. And please jump in if I'm missing anything. And that's sort of a classic one. Or it could be the neighbors are out to get me. And that's it. That's everything else they're pretty much doing okay. But once you have multiple delusions, the odds of you having many delusions about many different themes and not having other symptoms, that's very unusual, like very, very unusual. So an unspecified delusional disorder as a diagnosis is a bit of a cop-out because it's like, yeah, I don't know, he's delusional. It's like just telling me a symptom. It's like going to the doctor with a cough and the doctor says, you have an unspecified cough. Like that really does me a lot of good. You'd rather the doctor say, I think you have pneumonia. That's what we're going to work off of. And we're going to go from there. And if we're wrong, we'll adjust the treatment as we go along. So whatever doctor, and it's probably like one of my close friends who made this diagnosis, whatever doctor made this diagnosis hedged to the point of kind of absurdity. And so delusional disorders are usually very circumscribed, and that's your only problem psychiatrically. Because if you have a delusional disorder and you're depressed, then you have depression with psychotic features. So that's delusional disorder over here. And what unspecified means is that it doesn't fit any category. So if you look at the DSM and it just gives you a sort of a cookbook of if you have this symptom for this long and that symptom for this long, you have this illness. It's like an algorithm or a cookbook. And what this unspecified means is it doesn't fit in the cookbook. So we're saying it's delusional disorder and it's unspecified because we don't know something. You're supposed to say why it's not specified. So it could be it hasn't been long enough, or it's multiple things, or he may have other symptoms. So you have to hedge your bets even in that diagnosis, which I think is an improvement from the last DSM, where you have to, if you're going to give an equivocal diagnosis, which psychiatrists do a lot of, you have to explain why you're equivocating. So it used to be in the past, everybody was NOS, not otherwise specified. So psychotic disorder, NOS, and I'm like, okay, that could be almost anything. And so a lot of people got psychotic disorder, NOS, but now with the new DSM, you're not allowed to say not otherwise specified. You have to say not elsewhere specified, right? I forget the exact thing.
I honestly think unspecified. is the word
Unspecified.
we use from
So unspecified and I think unspecified and not elsewhere specified. But the idea is you're supposed to then say why not. So you say this is psychotic disorder, not elsewhere specified, doesn't meet the criteria for schizophrenia because they've only had symptoms for 5 months, but they don't also meet the criteria for schizophreniform because of something else. So that's how we're supposed to hedge now. We're supposed to hedge with an explanation. So just an unspecified delusional disorder, it should say why it's unspecified. So delusions often go hand in hand with hallucinations. So I hear the neighbors and they're talking about me. So and they're saying that they're going to kill me. So that's both possibly a hallucination and a delusion because I hear the neighbors, but let's say you're the investigator and you know for sure there was no neighbors next door and the TV wasn't on or something. So you know there was no actual sound causing that. So that would be a delusion and a hallucination at the same time. What can also be very tricky is someone can have what's called an illusion. So if you're at a party or you're in a crowded room and you hear your name called, it's a very common thing. Don't worry, you're not psychotic. You might be.
What is it?
We'll talk afterward. So let's say Ben is hanging out with a large group of people and someone goes, Ben, and he looks around. He's like, what? I thought I heard my name. And everybody's like, no, you didn't. Most likely he'll say, oh yeah, no, I probably didn't hear anything. But he could also say, no, someone is calling my name. And then he could spend the rest of the party hunting that person down and convinced that they're out to get him. So that's really a delusion, but there was no hallucination. He's delusional that people are out to get him and they're talking about him, but it was kicked off by an illusion, if that makes sense. So I guess the point I'm trying to make is these things are very sort of fluid. They on paper, they look very nice and clean and cut, but in reality, it's sometimes very hard to tease out what's a delusion, what's hallucination, what's partially true, what's reality-based, and what's an illusion. So, and even with delusions, they sometimes can have some truth to them. The neighbors are out to get me. They spend all their time trying to plot against me, and maybe the neighbors are going to City Hall and complaining about you. So often delusions go on top of reality, which makes it even more complicated. So all these things together make it difficult. What's nice is if you're looking at a primary illness, I think one of the things to really look at when you're out in the field is disorganization. And disorganization, I'll talk a little bit about disorganization. What's so important about looking for disorganization is it's pretty specific for schizophrenia. So if someone's delusional and you're not quite sure if they're delusional and are they hallucinating, they're not hallucinating, but they're really disorganized. I mean, the only other possibility is drugs, but even drugs don't really cause that kind of disorganization generally. So what disorganization means is you can have disorganized behavior, and you can have disorganized thinking and speech, and those are separated. So disorganized speech would be like right now I'm talking and I'm trying to make sense, and my thoughts are going linearly, they're going one leading to another, so they somewhat make sense. But I every now and then try to fake this kind of thinking, and I'll do my best. So if I have disorganized speech, I might say, so hallucinations, that reminds me of when I was a kid and I was feeding my dog, and then my cat ate the dog. And then my homework was late. And then yes, I have to get to the store tomorrow to buy some bread, right? So that even that, you can see that there's a thread. I went from cat to dog, which makes sense. I went dog to homework, which kind of makes sense because everybody thinks homework, the dog ate the homework. And then I went from homework to errands. So even trying to fake it the best I could, there's sort of a rationality underpinning it. But if I was really disorganized, you couldn't even find the underpinning. And it's really hard for people to fake, and people don't think to fake it. And so I know that not everybody's out there faking mental illness, but it's nice to know that this is one, if someone's got this symptom, it's probably a mental illness. So if they're talking and they're kind of all over the place and they're not making sense, that's disorganization. And then disorganized behavior, I'm sure you guys have all come across before too, is you go to someone's house and they say the neighbors are following me and they're saying all this thing, and I have proof. And you say, okay. And then the proof comes and it's just a pile of literally disorganized papers or, stacks of random things, or it could even be like, look at this tennis ball that proves that they're out to get me. I'm like, well, what about the tennis ball? Oh, they threw it at the house the other day and now it's marked with a computer chip and can't you see it? That's disorganization. So and another classic disorganization is I actually had a patient who would wear a tinfoil hat because he thought it stopped the mob in the East Coast from reading his thoughts. And, worked about as well as the medicine. But so that's disorganized behavior. So even though there's an underpinning to it, he's doing it for a reason, it's still disorganized. Another example I have of disorganized behavior is we had a patient, this is at the VA a long time ago, who in the middle of summer would wear layers and layers of clothes, like just heavy layers of clothes. And so that's a disorganization, and that's a potentially dangerous, and that's why he got into the hospital. And this guy came in with very high blood pressure, and we spent probably a month balancing his meds and getting him his blood pressure healthy. And then we discharged him, stopped all his meds, again with all the coats, just completely disorganized, came back in, his blood pressure was perfect. We're like, what? So that's sort of an aside. But the point being is that this disorganization is a very nice thing to look for. It's also there kind of all the time. So it can get better or worse, but if someone's schizophrenic with disorganization, and most people with schizophrenia has disorganization, not all, but if someone has that, that's one of those symptoms that's kind of always around. They don't suddenly organize. They might be more organized, or they may organize well around talking about football, and then you talk about their delusion and they just totally unravel and they're completely disorganized. So disorganization is a nice one to look for. The other one in schizophrenia would be negative symptoms. So, not shaving, not bathing. This sort of classic is, I remember there's a string of homeless camps, and then you see the one person way off another 50 yards away, scruffy beard, kind of to himself. Odds are that person has schizophrenia, because even among the homeless society, they don't want to hang out with people with schizophrenia because they're disorganized, they're hard to predict, and they just feel foreign, which is sad because the treatments do help and people can live very good lives. And that's one of the things that was really important with my training, was that I remember after doing all the inpatient work, and you see devastating case after devastating case, and then you go and do some outpatient clinics, and here comes a guy who's been living with schizophrenia, has a job, is doing well, and is taking meds. Like, I remember asking my attending, like, what? There's people are like this? And I'm like, yeah, of course, dumbass. And so,
How did you get into the building?
you are so bigoted. Yeah, so no, and that was a really good learning experience, because people can get better and they can stay better. You guys don't see them. And so, but even people on medicines, they usually have some residual symptoms. And then one last thing, well, we're waiting for Ramon. Oh, is he here? Oh, okay, well then I'll stop.
Awesome, thanks.
So Doc, real quick, you would just recommend if he didn't get another eval while admitted now in the hospital to get another one? Because there
Just
was a
make
cop
sure he
out of
gets-
the first.
Yeah, no, I would definitely make sure he gets to site
Yeah.
services, absolutely, yeah.
Great, thank you.
Yes, please don't quote me. Our doctor.
Oh, shucks.
I didn't realize he was there.
Thanks, Doc. Any other last minute recommendations for this case? We have quite a few good ones already. Thank you for those who have contributed. Any last recommendations?
Detective, this is Mike again. if you're comfortable sending me his name and date of birth, I can look up his probation parole history and see if he's on supervision now or what unit he was supervised in before.
And Mike, in that case, would they try to do it into the same unit? Do they try to keep it the same?
It might not be a bad idea, especially if he's known to a particular officer.
Okay,
So I could advocate for that depending on the disposition of the case.
great. Thank you for that.
You're welcome.
All right, thanks, everybody. We're going to go ahead and move on to our didactic. We are lucky enough to have Dr. Paul Romo, who's sort of a veteran of CIT ECHO here and always a great presenter. He's going to be presenting on opioids and the correctional system. So I won't take up any more of your time, Dr. Romo. Thanks for being here.
I appreciate you. Can you all hear me okay?
Yes.
All right, let me get into some screen sharing for you. And thank you for that introduction. All right, so I don't have any disclosures except that I do work for the MDC methadone program. And so I'll be able to give you a little deeper insight on what happens after the arrest and when patients end up in the correctional system. And so I'm also going to give any learners a backdrop about some of the crime statistics and the landscape and the terrain that a lot of the patients are in, as well as a little bit of details on fentanyl, since we're still learning about it in terms of it becoming one of the predominant substances of abuse. Well, that'll feed into treatment modalities, and then I'll give you some insight on what's going on over at MDC. And we'll wrap it up with a question and discussion session if you have any details about it. A lot of the information is not directly on the slide, so since it's being recorded, hold questions until the end. That way we can do an overview and it's not as choppy.
Dr. Romo?
Yeah.
Do you think you could make a full screen of your, because I think
Yeah.
you're in like a presenter mode.
Yeah, I thought it was. Let me see if I could get that for you real quick.
Thank you.
I'm gonna stop it and then reboot it. Thank you for your patience, by the way. Are you all able to see this a little better?
Yeah, we're good.
Oh, no, there it is again.
Okay. Are you seeing it in full screen?
No.
Presenter mode.
Okay. Let me try one more thing real quick. Hey, do you all have my slides?
I do, but unfortunately I'm not logged in this computer. I can try logging in on my end.
I wouldn't. Let me try one more thing real quick because it's the one that it's probably the one that I'm selecting. That's so weird. I don't know why it's doing that.
Don't worry about it.
Should we
That's
just
actually better like that.
should I just let you be privy to what's behind the curtain?
Yes.
All right. Well, anyway, let me just take you right into some of the landscape and the terrain. So this is from a database provided by Chief Griego about crimes against persons. And what that entails is it's a classification of crimes against people like rape and murder. And so we see a trend going up in terms of murder. This is problematic because this affects the whole community, from the officer that has to tell the family what happened to families themselves. But we can see the rates are higher. Chief Medina was trying to elaborate why this may be, because they don't know what's happening behind the scenes for a lot of these. They suspect though that it's drug related, possibly fentanyl related. And the reason they think that is because a lot of them are concentrated in areas where there's a lot of drug activity in motels and parks. And so if you look at this graph where it's lit up, there's a lot of activity that's known as the war zone. And so we're seeing a lot of crimes there. Most likely they're connected to substances. And so that right then and there takes you a little bit into the world of the patients that you're going to encounter. A lot of them live in these concentrated areas, and a lot of the calls are emanating from there. In terms of property crimes, for a while, we were #1 in property crimes nationally. I think that the peak was 2018. And so we're seeing progress in terms of that. But property crimes are things like auto burglaries and things like that. So those are actually improving quite a bit. I don't know, 46,000 is still quite a bit. I myself had my sunglasses stolen from my car just the other day. So if you see, you guys are out and about, if you see somebody with some Ray-Bans cleaning a bus stop with a toothbrush, all high on cocaine, for sure, those are mine. Get them for me. Now this is also something that all the patients that we encounter face, the ones that are using substances. This categorization is crimes against society, and this includes things like prostitution, drug dealing, and things like that. And we see this is on the rise. Among this rise is fentanyl. And I just wanted to give a quick background on fentanyl for those that aren't fully oriented about it. What it is it's a high potency synthetic opiate. And so if you see the abbreviation HPSO, what that means is basically an acronym that categorizes these types of opiates. You're going to see HPSOs more and more as they produce more literature on it. So I wanted to introduce you to that term. But part of the reason fentanyl is such a problem is because it's 50 to 100 times more potent than than morphine. And the one at the end, carfentanil, that one's I think 10,000 times more potent than morphine. And so these drugs cause problems, but the drug in itself isn't good or bad, right or wrong. It's just a tool. The problem is when it's not used by an anesthesiologist or a medical setting, you get high rises of substance use, high rises of accidental overdoses. And this is the black box warning that goes with fentanyl. But if you all see the bold word intranasal, it should never be used intranasal. But how many times have you heard of a patient or a person crushing up one of those blue counterfeit fentanyl pills and snorting it? So right then and there, the route that they're using it is extremely dangerous. This isn't just a local problem. Coast to coast, our opiate overdoses are up almost 30%. And this is largely due to these higher potency synthetic opiates. This is a graph of the overdoses, and they've passed 90,000. If we look at it for November 2019 to November 2020. It's the same thing for our state. And so there's no way around it. And people would say, why would people do opiates to the point where they're constantly overdosing and pushing the limits? Well, if you look at the center of this graph of a brain or drawing of a brain, you see two areas. The ones in red are the ones I want you to look at. So there's areas that when opiates hit the brain, they'll cause a lot of pleasure, a lot of euphoria, and it kind of activates the reward system. So people do it over and over again. But it also shuts down a part of the brainstem in the medulla called the respiratory drive. And so you have these two areas competing where people will constantly push the limits to see how high they can get. Once they nod off, or it's not too far past that where they can fall up, meaning that they accidentally overdose. And it's because of the opiate activity at the brainstem. Anyway, we have 3 FDA-approved treatments when somebody's trying to get away from addiction, and that's methadone. It's a liquid. You can get it from dispensaries that are distributed, and I think there's a total of 11 now, but it's pretty structured. good place to get treatment. And this is the option that we have over at MDC right now that I'll take you into. We also have buprenorphine, which is the active ingredient in Suboxone, and that comes in a pill strip or an injectable form that lasts a month. And it's the same thing for naltrexone, that's a opiate blocker. And they have different properties that I'm not going to go into, but with methadone, you can continue going higher and higher to get control of somebody's craving and withdrawal. If something like Suboxone, this middle graph, doesn't cover their craving or withdrawal. The one at the very bottom is the opiate blocker. That's also a useful tool in correctional facilities. But if we leave people in the community untreated, this red bar shows that there's quite a few overdoses and deaths. When you treat people though, you get a lot fewer deaths. That's the blue bar, medication-assisted treatment. And that's kind of what we want to drive patients toward once we encounter them. And so it's never as simple as just a medicine. The other elements that are required for people getting into recovery are making sure that their health problems are under control, that they have stable housing, a sense of purpose, and this could be something as simple as a job at Walmart, that they're connected to a sober community, and that their self-efficacy starts to build, because addiction has the ability to degrade these quite a bit. Now, the majority of the people aren't getting treatment just right off the bat or voluntarily, and so that's where they can interface with us, with CIT, with APD, or if they're in MDC, and start to get treatment. The number one treatment right now over there is methadone, but we're contracted to start Suboxone soon. And there's also a lot of studies that look at giving people Vivitrol. Reason that this is important is that it's pretty much a unavoidable component of our society now. I think in June, sometime in the summer of last year, I think it was June, we surpassed incarceration rates of China, becoming the number one country that incarcerates their population. So there's no way around this. So we might as well try to use this as a way to also introduce people that are incarcerated into treatment, because they're there. It's costing the country and our communities millions, and on coast to coast scale trillions. For most average people, general population, there's a 1 in 100 chance they'll get incarcerated, and it becomes less than 1 in 20 for minorities. Now, if we just look at the people that are getting arrested and the people that are incarcerated, whether it's at jail or it's in the Department of Corrections, 50% of those cases have some kind of substance-related problem connected to it. If that's untreated, the outcomes that are associated with it are a lot higher, meaning that HIV rates are higher, hepatitis C rates are higher, crime and recidivism are worse, overdoses are worse, and they've even there's been studies in our country as well as other countries where they looked at the overdose rates for when they get released, and they're extremely high. What happens is people end up getting arrested and incarcerated. They lose their tolerance because it's harder to get opiates consistently, and they go back to the same lifestyle that they had before they were arrested. And so this graph, this blue bar shows overdoses that happened the first week of people getting released from prison, and it's extremely high for that first week. So you'll see studies where they'll try to give people opiate blockers and different interventions, but without treatment, the overdose rates for these folks are extremely high. If you look back a couple years before the fentanyl era, you see the exact same pattern where people involved in the criminal justice system have higher rates of overdoses, sometimes as high as twice as much. And so that's even amplified now that we're in the fentanyl era. And so there's multiple intervention points. The ones that CIT may have may be when a call is made and you end up on the scene. Others are when they're in drug court or they're routed through pretrial services. But the one I'm going to concentrate on is the intra-system programs. That's when somebody's incarcerated, what treatments they have available But I have to say it's ineffective if when they're released, they don't have anywhere to go to. And so the other pieces are equally important. So once they're released and they re-enter, there has to be some kind of system where they can connect to. So for example, if we start somebody on methadone at MDC, we ensure that they have a clinic that they can follow up. And so they'll pick one of the 3 top clinics, and we try to encourage them to pick one that's closest to where they live, since they'll have to frequent that clinic regularly before they earn take-home doses and stabilize. There's other programs that UNM are involved in, including jail diversion services, who have several overlapping patients with us. And so try to imagine it as a spectrum, and the slides that I'm about to show you are just a little cross section of that. When we look at the places that do offer medication-assisted treatment, we see that we get reduced opiate use, lower criminal behavior, we get decreased overdose rates, and infectious diseases also goes down. And so the patients that are involved and have access to some of these programs benefit greatly. It doesn't matter like where you look, wherever they're doing one of these programs, you get similar findings. And so if you look at the 4th bullet, even economically, whether it's places as diverse as Rhode Island or Australia, you get these same kind of benefits. So even though there's a good body of research saying that medications for opiate use disorder have these benefits, you very rarely see them implemented in criminal justice systems across the nation or even our state. We had a meeting with some people in Roosevelt County Detention Center who are trying to get a program going. So there is movement. It's just right now there's a lot of inertia. This slide mentions Rhode Island. I did want to give them a little shout out since nobody knows anything about Rhode Island at all, except for maybe Nils. Anyway, I always thought the Rhode Island could break away like a raft and just float away, and even the people on it wouldn't know, but I think I better stop before I put my foot in my mouth and Nils comes and gets me. Anyway, so they did a study in Rhode Island. They broke down the costs of what it would take. $14, you could get somebody treated that takes care of the counseling, the doctor, the urine test, the medicine. And they have that breakdown for each of the substances, so it works. A lot of times it costs way more than that to continually reincarcerate somebody. It costs a lot to continually have CIT go to the same household. And so if they need to be arrested, taken out of their environment, sober up, we need to try to use that window of opportunity to get them treated and see if we can break the revolving door. This slide just shows that this has been studied in both detention centers and prisons using those 3 FDA-approved medicines I was talking about. And so we have a lot of data that it works. We don't need to reinvent the wheel. And we also have the ability to treat people during the COVID pandemic. So this study was looking at the same work and implementing a program during COVID, and they could get it to work. They just had to reduce the scale of the program and make sure that there was a place for the patients to connect to once they were released and could re-enter into society. If we look at even larger scales, this is a meta-analysis of random controlled studies where they looked at 800 and some inmates that were in the program. And this is how to read this graph. If see where the number 1 is on that graph, and then outward it goes 10 and then 100, and the opposite way it goes to 0.1 and 1. The further away from the middle of that, the better the results when they looked at all these people together. So if you look at the first top squares and triangles, patients that were able to access these medicines engaged a lot more in treatment, and that includes follow-up. The next category means that they injected a lot less. The next one was that there was a mixed results about if they were reincarcerated or not, but the majority of the studies showed that the reincarceration rates went down and also the relapse rates went down. If we look at a survival analysis, if you look at the top line, that's people that didn't struggle with substances. The green line just below that is people that were on methadone. So what they found is that a lot of them would stay out of jail a lot longer compared to people that were only getting these medicines to detox off of them and not to stabilize and use them as maintenance. They used alcohol, which is the yellow line also at the bottom, that looked almost exactly the same as a control. And so we know these medicines work. This is a study that we did over at the jail. If you look at the dotted line, what that is that's people that have opiate use disorder but did not get the medicine. In this case, it's methadone. The solid line are people that had access to methadone. And so if what they did is they looked at them 3 years before the treatment, they were relatively the same. And then they started methadone and see where the two lines split apart. The ones that are represented by the dotted lines are people that did not get treatment for their opiate addiction. And so there was a 40%, 50%, 60% chance that they ended up getting rearrested as the study went along. But the people that were on methadone maintenance, the percent chance that they got reincarcerated was a lot less. It almost stabilized and leveled out. This slide is a little more boring, but what it basically says is it costs $116.49 for somebody to be at MDC. That's something that's paid for like by taxes through people that live in Bernalillo County. And what this graph says is that if we're willing to pay somewhere between $45 and $60, where that curve goes up and levels out, there's a 90% chance that that person won't be rearrested, and that putting that money into a program like a methadone program or a Suboxone will actually save the county money, because that same person won't be rearrested over and over. In order to do this on different scales, they looked at other programs that were starting up and some of the barriers. And so in order to do this, we have to have leadership on board, and that's not only county commissioners, but that's also people like wardens, like the chiefs at detention facilities. Stigma also has to be addressed, and that's from the ground up, from the family that a CIT officer is going to, all the way up to these larger superstructures that patients end up getting tangled into. And so the more buy-in and the more activities that we have like this ECHO, the more we can break up the stigma and provide education on how to treat these problems from different angles, because they're not going to go away unless we take a proactive approach. Once a program's going, the key ingredients are that it has to be designed in a way that's sustainable, and there's a lot of turnover in the correctional system, and so continuous training is required. The ties with the community have to do with having a handoff. So once a patient is released, that inmate needs to be plugged in with either a methadone clinic or some kind of addiction clinic. We're working with county commissioners, county leaders. This includes county commissioners in some cases, on how to form stronger networks so that there's faster turnaround time when a patient's released to when they can link up with a clinic. Right now, if we start somebody on methadone, for instance, they can go to one of the clinics of their top 3 choices, and they can do something called courtesy dosing, meaning that they'll stay dosing at the same level until they can get an actual intake into that program. And so we're coming up with different ways to approach this. And then you'd be surprised at some of the barriers. Sometimes it's as simple as a person not having identification. So what we do in those cases is we'll let them use their bracelet or their jail ID card as verification to buy them more time to get either their license or their ID card. And that in itself can be a pain. The last one is that all these programs have to have systems in terms of controlling the dosages. Some of them are controlled substances. Controlled substances and within a jail are extremely valuable. So good system about conveyance and monitoring for diversion are important. And the diversion itself is extremely difficult to control. So we have to do mouth checks. Sometimes they'll do this technique where they'll try to put some teared cloth or something under their tongue and let it absorb the methadone. And then they'll try to sell that later. The more advanced people the most advanced system I've seen so far is they'll take that same cloth, but they'll take a piece of string out of it and tie a knot at the end, and they'll wedge it in between their back molar, like a dental floss, and then they'll swallow that. They'll drink the methadone, and then as soon as they can, they'll like pull it up out of their mouth. So pretty creative stuff, but we need to be conscientious of that when we roll out one of these programs in a correctional facility. Anyway, we have there's diagrams available, so the wheel doesn't need to be reinvented. We have systems of how to do the screening to make sure that somebody has opiate use disorder. And this is where collateral from CIT, APD, the medical can become really useful. A lot of times it's not something that they're going to readily admit when they get arrested. We also want to make sure that if they're arrested at MDC or another facility, that if they have to be transferred to a place where they don't have treatments for opiate use disorder, that they don't get into the program, because what that'll do is that'll force that inmate to go through withdrawal twice. So it's better just to pull the Band-Aid real fast. Systems to dispense medicine, program requirements so that they can thrive and succeed in the program. And reentry is basically what happens when they go from incarceration back into the community. If they engage correctly, what the studies show is that they'll be contacting CIT less, that these folks stabilize a lot better compared to those that don't. And then I'm going to take away the screen share and we can just open it up for any questions or discussions